guys, welcome back to our endocrinology chapter. In this section, we'll be talking about diabetic ketoacidosis, and this is a complication of diabetes that I want you to associate with type 1 diabetes, HHS, which we'll talk about in a different video, more associated with type 2, but DKA with type 1 for this video. And the pathophysiology of diabetic ketoacidosis, what I want you to remember is that this is an anion gap metabolic acidosis. Remember our anion gap equation, all the sodium minus the bicarb minus the chloride. This number should be greater than 12 if this is an anion gap metabolic acidosis. And how does diabetic ketoacidosis lead to this anion gap? Well, what's happening in diabetic ketoacidosis to cause this anion gap is, although you may have high levels of glucose, you may have hyperglycemia in the 200-300 range, you will have decreased insulin. And this decreased insulin is tricking your body into feeling like it's in a fasting state, like it doesn't have any glucose available, even though you may have very high levels of glucose in your serum. Because you're in this fasting state, or your body thinks you're in this fasting state, this will lead to your body wanting to get energy from different sources, and one of these sources will be the breakdown of lipids, or lipolysis. The lipolysis will lead to ketogenesis in the liver. As these lipids break down into free fatty acids, they will go through ketogenesis in the liver. And as we go through ketogenesis and make these keto acids, they're going to need to be buffered. As these keto acids are buffered, this is what leads to the consumption of bicarbonate. And if we have lower levels of bicarb up here to offset the sodium in our anion gap equation, that is what is going to contribute to the anion gap metabolic acidosis seen in DKA. And before we get any further into our discussion of DKA, I want to direct your attention to this image down here because I think it's really helpful to help us better understand what's going on at the biochemical level in this process. So what's happening here in this pathway is when you have decreased levels of insulin and increased levels of glucagon telling your body that you're in this fasting or unfed state, this is going to lead to increased lipolysis, as we talked about above. We're breaking down our lipids to make these free fatty acids, which can be used as another form of energy. These free fatty acids are transported into the liver via carnitine palmitoyl transferase 1. If you remember the carnitine shuttle system, that is what is moving these free fatty acids into the liver. Once in the liver, these free fatty acids can undergo beta oxidation, and this beta oxidation is what is going to give us these 2-acetyl-CoA that we are starting out our pathway with. Once we have these 2-acetyl-CoA within our liver mitochondria, then we can start the process of ketogenesis. There's a lot of intermediates in this pathway that I don't think it's worth your while to memorize. I just really want you to focus on the general overview of this pathway, as well as 3 important keto acids themselves. So as we're going through this pathway of ketogenesis, the 3 keto acids that we are going to generate are number 1, acetoacetate. It down here gets converted into acetone. And this is actually the keto acid that, along with CO2, we are going to breathe out of our mouth. Acetoacetate converted into beta hydroxybutyrate. And this is another key keto acid here that's definitely important for you to remember. And then once we have generated these keto acids through our process of ketogenesis, these keto acids can travel through your blood from the liver to target tissues. So that's why we went through this process, because we needed to take our free fatty acids and create a form of energy that we could transport from the liver to other tissues that could use them. The keto acids can cross the blood-brain barrier and are a source of energy for the brain when we don't have enough glucose. They can also travel into other tissues, and once they get into distant organ mitochondria, beta hydroxybutyrate can be converted back into acetate, and then acetoacetate can be converted back into acetyl-CoA, and thus we have transported the energy stored in the form of free fatty acids to target tissues where this energy has been converted back into the form of acetyl-CoA, which can then go through the citric acid cycle, the electron transport chain, generating ATP that the cells can use. So general overview of this pathway: in times of starvation, when we don't have glucose readily available, we can break down some of our fat stores going through lipolysis, create some free fatty acids that the liver can convert into these keto acids for transport to distant tissues, which can then convert the keto acids back to 2-acetyl-CoA, which can then go through the citric acid cycle and the electron transport chain to provide those cells with ATP. And reviewing this process in the context of DKA, what's happening is this decreased insulin is leading to a false starvation state where you have increased glucagon, increased cortisol, increased gluconeogenesis because we're making more glucose because we don't think that we have it in our body, increased glycogenolysis, so we're breaking down our glycogen stores, and then finally the increased lipolysis, as we talked about down here in this diagram, is what is going to lead to the release of free fatty acids. This is what travels into the liver and increases the hepatic ketone production. Our keto acids, very important to remember their names: acetoacetate, acetone, the one we breathe out, and beta hydroxybutyrate. As these keto acids are in your blood traveling from the liver to their target tissues, this is going to decrease the pH of your blood. These are acids, so they are going to make your blood more acidic. The bicarbonate buffer system is trying to fight against this and maintain a normal physiologic pH in your blood, even in the presence of all these keto acids. And as bicarbonate is consumed as a buffer for the acidic ketones, that is what is going to lead to our anion gap metabolic acidosis, as we discussed over here. Having a lower bicarb in this equation will certainly lead to a greater anion gap, as there is less bicarb to subtract from the sodium, meaning it's more likely that this number will be above 12. In addition to the anion gap metabolic acidosis that is classically associated with DKA, DKA can also lead to renal injury. So when you have this hyperglycemia that is uncontrolled, this leads to an increased plasma osmolality, as we discussed in our physiology of diabetes section. This can lead to osmotic diuresis, which will cause hypovolemia. And it's this hypovolemia that really damages your kidneys because they're not getting perfused as readily. And this hypoperfusion can lead to a decreased GFR as well as azotemia, so increased BUN and acidosis. And then one final note about this pathophysiology that is incredibly important is the hypokalemia that can be associated with DKA. So the hyperglycemia and the hyperosmolality that we see here is going to lead to an increased potassium shift into the extracellular space. Decreased insulin means there's also going to be decreased potassium uptake into cells. So you have potassium shifting out of cells and water shifting out of cells down the osmotic gradient, pulled by the high level of solute, the high level of glucose in your blood. And then additionally, you have a lower ability to take up potassium into cells because that does require insulin. This will lead to a very interesting phenomenon in which we do have total body potassium depletion. Okay, so we're peeing out our potassium as well. Remember, we have total body potassium that's low, but we'll have normal or hyperkalemia on lab values because all the potassium we do have has shifted into this extracellular space. We can't get it into the cells because we don't have enough insulin to uptake it into the cells. So we'll have quite a bit of potassium in our blood, even though our total body potassium is low. Complications of DKA, one that's associated with the hypokalemia, is the arrhythmia. Remember that electrolyte abnormalities can lead to arrhythmia, and certainly hypokalemia here can lead to arrhythmia, as well as mucormycosis. That bread mold infection of the nares and often face is associated with DKA. The presentation for DKA, so it's going to be a patient with type 1 diabetes. Remember, I said associate DKA with type 1. And then inciting events of DKA are going to be infection, a new diagnosis of type 1 diabetes, a heart attack, pancreatitis, lack of medication. So if a patient hasn't been taking their insulin for whatever reason, that is a quick recipe to get someone with type 1 diabetes into DKA, steroids, or thiazide diuretics. So basically anything that's a shock to the normal system, an infection, pancreatitis, a heart attack, anything that damages the normal system of someone who does have type 1 diabetes puts them at increased risk for DKA. And then a lack of medication or non-adherence to medication, so teenagers who don't want to take their insulin, or people who maybe can't afford their insulin or for whatever reason haven't had this life-saving medication, that can rapidly put someone with type 1 diabetes into DKA and is very dangerous for them. Symptoms of DKA, often they'll present with nausea, vomiting, abdominal pain, Kussmaul breathing, so that deep, rapid breathing to breathe off all of this CO2 and acetone. Their breath may have a fruity odor because of the ketone specifically, altered mental status, or a coma. And as I mentioned in the previous video, DKA can often be the first presentation of someone who has type 1 diabetes and doesn't know it yet. Additionally, they're at higher risk for arrhythmias and renal damage. The diagnostics of DKA, so usually you're going to have a blood glucose above 250. Remember, we talked about how it's not a problem of not having glucose, it's a problem of not having insulin to tell your body that you do have glucose or be able to use the glucose. Usually the blood glucose will not be above 600. That's more characteristic of HHS, which we'll talk about in the next video. However, this is not a hard and fast rule, and in clinical practice, you certainly may see someone in DKA with sugars well above 600. I don't know if they'll follow this rule exactly on step. They have in the past where if they show you a sugar above 600, it's more likely HHS. So a good clue to look out for, but not something that I would hang my hat on for a diagnosis. Something that is characteristic of DKA and less characteristic of HHS is this anion gap metabolic acidosis. So really important here to remember that you'll have an arterial pH less than 7.3, the definition of an acidosis, as well as decreased bicarb. We've talked about how bicarbonate is consumed as a buffer for all the keto acids, and that is what leads to the anion gap metabolic acidosis. You'll have ketosis, so all of these ketones that are floating in your blood also come out in your urine. Electrolyte abnormalities, so we've discussed how even though you might have a normal serum osmolarity, which will be different than HHS, you can have hyponatremia as well as normo or hyperkalemia, even though, and I can't stress this enough, your total body potassium is depleted. So you might see hyperkalemia, so high amounts of potassium in the blood, but remember, your total body potassium is low. and then you might see leukocytosis as well as hypertriglyceridemia. Now, management of DKA is actually going to be quite important for the order here. The first thing you're going to want to give them is fluids. This is a dehydration problem. Remember, we talked about the osmotic diuresis that goes on up here. So make sure you give these people fluids, and it should be normal saline. The next thing you're going to want to do is replace their potassium. And why are we doing this next? Remember, insulin is what is going to lead to potassium uptake into cells. And if we shift all this potassium into the cells, when we know we have total body potassium depletion, that is going to lead to a very drastic hypokalemia, which can cause arrhythmia and even death. So we don't want to do that. We want to replete the potassium before we give the insulin. Once we've repleted the potassium, then we can give the insulin with the glucose. And as we just discussed, if we do this step backwards and we give the insulin before the insulin will cause the potassium to shift into cells, leading to a hypokalemia if we're not careful. So we really want to give that potassium first and then give the insulin. We monitor the success of resuscitation in DKA by checking the anion gap. So keep looking at the anion gap, and this anion gap should normalize, and that'll be the sign that you have treated their DKA well. Once their anion gap has resolved, then we can start them on long-lasting insulin and begin an insulin resistance is their first time presenting with diabetes. I know that was a ton of information. Let's quickly recap what we went over in this video. So DKA is seen in type 1 diabetes, usually in the setting of another stress to the body like an infection, a heart attack, or just lack of medication, lack of insulin. This decreased insulin is going to lead to increased ketogenesis in your liver, which will lead to an anion gap metabolic acidosis, this small breathing, breath with fruity odor, and very importantly, depleted total body potassium, even though you may have high levels or normal levels of potassium in your blood. For treatment, it's important to give fluids first, then replete your potassium, and only then give insulin with glucose so we don't cause a dangerous potassium shift into cells and out of the blood, leading to an arrhythmia. And then how would they ask you about this on a board style question? Well, something they might ask is, a 5-year-old boy is brought to the emergency department by his mother after 3 days of vomiting, abdominal pain, and increasing lethargy. Mom was unable to wake the patient when she went into his room tonight. Labs are remarkable for a glucose of 350, a bicarb of 12, a sodium of 135, and a chloride of 101. The patient is started on insulin with glucose. An hour later, an EKG reveals T-wave inversions and prominent U waves. What is the most likely cause of this patient's EKG findings? So our patient's 5 years old, he's had nausea, vomiting, and now he has altered mental status, so he's unresponsive. Mom can't wake him up. And at 5 years old, with no known medical history, this is a classic presentation of AA in an unknown type 1 diabetic patient. The labs confirm this. We look at the glucose, we see a glucose of 300, and if we calculate this out with our sodium being 135, our bicarb being 12, and our chloride being 11, this gives us an anion gap of 22, which is certainly greater than 12, so we know that this is definitely an anion gap metabolic acidosis, and in the setting of the high glucose as well as the classic presentation, this certainly looks like DKA. The question tells us that the patient was started on insulin with glucose, and then an hour later has a weird EKG with T-wave inversions and prominent U waves. These are both signs of hypokalemia on EKG, and the question asks us, what's the most likely cause of the patient's EKG findings? Well, the patient has hypokalemia, that's what those EKG findings mean, and the question also tells us that the patient was started on fluids and insulin with glucose, but we skipped a very important step. We did not start this patient on potassium replacement, and that would likely be the cause here of the hypokalemia causing the EKG findings. So if I were answering this question on step 1, I would look for an answer that says inappropriate shifting of potassium into cells, total body low potassium, inadequate potassium replacement, something like that, to show that I understood that what was happening here is that we had failed to replete the potassium but had given insulin anyway, which shifted all this potassium into cells and not leading to arrhythmia. And that's all I have for you on DKA. I hope this video was helpful, and I'll see you next time.